Dr. Spinka, before we actually go into describing the technique, maybe you can give me some background on what you do before you begin a procedure. I know that some doctors have described landmarking.
Yeah.
What are you currently doing?
Yeah, after prepping, we do use some anatomical landmarks. We also occasionally do some nerve mapping to locate the nerve.
Okay. And with the nerve mapping, is that percutaneous stimulation?
Yeah, we have a specific stimulator that goes up to 15 milliamps. We have a probe that we touch to the patient's skin, and we look to elicit a specific muscle response. Oftentimes we'll take a sterile marker and mark the skin so we have a probable entry point for the needle.
Okay, so you're looking for an entry point whether you're doing landmarking or percutaneous stimulation.
That's right.
Okay, great. You would do the same thing with our StimuCath product as well. And I'm assuming that the components are probably somewhat similar. It's a 17 gauge actually TUI needle, but similar to what you described, it is insulated on the shaft. Again, I'm assuming this is similar to what you're currently using?
Yes.
Okay, great. The difference, which you described earlier, is the fact that you have a direct wire coming off of the needle. In the case of our product, we have a snare hook that connects on the exposed portion on the most proximal end of the needle. Okay? This alligator clip will then connect in onto your stimulator. So do you have a stimulator there?
Yes.
And so you have a male pin stimulator. That just connects right on there.
Mm-hmm.
And that sheath just can go right over. Okay. Now at this point, you would start, what do you typically start your milliamp settings at? Is it somewhere between 1 and 1.5?
Well, we always start at 1.5 milliamps.
Okay, very similar to what I've heard. Do the same thing with our StimuCath needle. Start at 1.5, penetrate where you've made your landmarks, and as you begin to localize the nerve and begin to get the twitch that you're looking for, you're going to dial down on the current. I'm assuming that most people have told me that they'll accept around 0.5 as an acceptable response.
Yeah, once we get some response at 1.5, we'll go to 1, and we'll look to get the same vigorous response.
Okay, so if I could demonstrate, you have, if you're looking for example, I don't know all my nerves, but if you're looking for a medial twitch and you're getting this at 1 milliamp, then you'll ask them to dial it down.
That's right.
And then it may go to just a real slight response, and then you try to make that stronger.
That's right. We will try to continue to approach the nerve until we get a very rigorous response, anywhere from between 0.3 to 0.8 milliamps.
Okay, and so that's your criteria for success, is somewhere between 0.3 and 0.8.
That's right.
Okay, I've very often heard that anything below 0.5 is very well accepted. Mm-hmm. Okay, excellent, excellent. Well, you do the same thing with our needle. Okay, so as you localize the nerve and you're at 0.5, you then will remove your stylet, take your StimuCath, connect the catheter, and you should get the same response that you had with the catheter, because this needle tip, or this catheter tip, excuse me, is conducting via the needle. So as soon as you enter the needle with the cable connection on the catheter, on the proximal end of the catheter, you should elicit the same response that you had before prior to inserting the catheter. Okay, does that make sense?
Yes.
Okay, now this is very important. There's a wide band, okay, on the catheter. That indicates, if the wide band is outside of the needle hub, that indicates that your needle has not yet advanced beyond the needle tip. Okay.
Typically we would have injected through the needle right after we get the proper muscle response at the right current setting. We would inject directly through the needle at that point.
Okay, I'm really glad that you brought that up, Dr. Spinka. That is one of the major differences between using the StimuCath and doing a single shot procedure or a non-stimulating catheter procedure. If you were to inject your bolus injection through the needle at this point, you would no longer be able to stimulate via the catheter. And the reason that is that whether it's a sterile saline or a local anesthetic agent, you disperse the current density at the tip of the needle, and therefore you will no longer be able to stimulate. We don't want to do that because we want to be able to stimulate via the catheter. Does that make sense?
Okay.
Okay. So the wide, going back to the catheter, the wide band, again, we're still not yet stimulating via the catheter. We're still stimulating via the needle. Our goal is to advance the catheter 3 to 5 centimeters, maintaining the same level of stimulation that we had prior using the needle. So as we begin to advance the catheter, we may maintain that same stimulation, but inevitably you'll lose stimulation probably greater than 50% of the time. And the reason is that we believe that the catheter is moving away from the nerve. At this point, without manipulating the needle, pull back on the catheter until you can see that wide band outside of the needle hub, then make your needle adjustment, okay? And this is very important because if you were to manipulate the needle as the catheter was advanced, you'd have a great potential for shearing the catheter, and we don't want this to occur. Okay, so again, going back, ensure that the wide band is outside of the needle, make your adjustment, advance your catheter, again with the goal to advance it 3 to 5 centimeters, okay? And you'll continue to do this procedure until you've maintained that same stimulation below 0.8 milliamps with the catheter.
There are centimeter markings on the catheter, so I know how far I've advanced the catheter?
Yes. Good question. Yes, as you're advancing the catheter, you can count 1, 2, 3, so you know exactly how far you've inserted the catheter. Okay. At this point, once you have maintained stimulation via the catheter, you would remove the catheter, or excuse me, remove the needle just as you would remove an epidural needle. Okay, and as you remove the needle, you can see that you also remove the stylet. Okay.
Mm-hmm.
So now we assume that the catheter is in the proper place, but we can check again by connecting the snare hook to the most proximal end of the catheter. Again, we're stimulating through the wire reinforced coils, not through the stylet, so you still should be able to see stimulation. Okay. And at this point, we would recommend some sort of securement of the catheter. And there are a couple options that I've seen out there. Some people choose to subcutaneously tunnel the catheter. Others choose to use a medical grade adhesive, and they'll just adhere the catheter via the adhesive directly onto the patient. I'd like to describe the subcutaneous tunneling procedure, just so you're familiar with that, if that's okay.
Mm-hmm.
I'm going to demonstrate using the packaging. If you don't mind holding that. You just want to put a slight bend in the stylet. Okay. Now let's assume that that's the catheter exit point. You want to go 2 to 3 millimeters away from the catheter exit point and subcutaneously tunnel with the stylet roughly 1 to 3 inches away from the catheter. Okay. And like other retrograde tunneling techniques, you would railroad the needle and retrograde tunnel back towards the catheter. Then thread the catheter through the needle.
So it's important that I keep the entire length of the catheter sterile during the procedure.
Actually, that's a really good point. This technique is done for securement of the catheter, not for infection protection purposes. And so you will have an exposed skin bridge, okay? And that's simply for easy catheter removal. The reason we're not concerned about infection are these catheters are typically pulled within 72 hours. And during that period of time, we're not tremendously concerned about infections, if that makes sense.
Okay.
Okay? And so that's what you end up with. Now at this point, you then can connect your snap lock adapter. Have you seen the snap lock adapter before?
It's very similar to the snap lock adapter used on the epidural.
That's correct.
Catheters.
Mm-hmm. The one difference is that you'll see that there's a metal exposed portion on this particular snap lock so that you can connect the snare hook cable. And again, check your stimulation.
Yeah.
Okay. You've confirmed placement. You can now do your bolus injection of local anesthetic through the catheter for your surgical anesthesia, and then the catheter is in place, so post-operatively you can also do your local anesthetic infusions.
Yeah. And also check catheter placement post-operatively.
You can do that if you're using another type of anesthetic for the surgical procedure, such as a spinal. Typically, once that spinal wears off, you could check. If you're doing providing surgical anesthesia via the catheter, you're probably going to have to change your criteria for success because instead of stimulating at 0.5 milliamps, you're going to have to stimulate at 2 milliamps in order to get the same motor response that you received before. So that's a good question. Okay. We also have a stat lock device, which helps for securement. And the stat lock device, you may have seen it before, but the snap lock would fit right into the stat lock, and this would adhere directly onto the patient. And this just helps to manage the catheter. Okay? Any questions?
So it's not until after I've secured the catheter do I actually give my initial bolus injection?
That is correct. Once you've secured the catheter and you've attached your snap lock adapter, you can then do your bolus injection through the catheter. And you're ensuring that that the catheter is in the correct place. You're ensuring that your local anesthetic is going to provide the proper anesthesia or analgesia that you're looking for.
Okay, thanks.